You've been a major supporter of the work of public health and global health, Judith. How has your personal focus and the focus of the foundation changed over the years?
Well, 100 years ago, as we were working on trying to find a cure for hookworm, and
now Judith, I assume was not necessarily yourself,
right,
on that.
The Rockefeller Foundation, trying to find a cure for hookworm in the South. They recognized, I think, after about a year of struggling to do that it wasn't an issue about finding the right vaccine or finding the right medical treatment, although that would be important, but that it really was about education and sanitation and poverty. And through that insight, the field of public health really developed. And it's so fitting now to think about all of the things that we've been talking about at this meeting, because bringing together all of the disciplines was, of course, the amazing innovation of the field of public health, medical sciences and social sciences and increasingly engineering sciences. And so as we look back both on that history and on the ability of philanthropy in each era to really step out and innovate or see a trend, see a wave, and then start investing in it. Fast forward another 20 or 30 years, Rockefeller was funding a great deal in physics and chemistry. And they began to understand that these sciences could apply to the life sciences and the biological sciences. And they funded Harvard and Columbia and Uppsala and University of Copenhagen, and the field of molecular biology was born. So in each successive generation, we've had the privilege and the responsibility, I think, to understand basic science, but to always put it in the context of the overall health and social ecosystem. And it's very heartening as we talk here about prosperity in the same framing as we're talking about health, that we really recognize that we won't have a prosperous society unless we have a healthy society, and that we certainly see that in all that we do. One could fund girls' education in Africa, but if a father or mother gets sick, they're pulled out of school and they're sent to the fields. So the complex ecosystem that was first reflected in public health is even more true today, where the complexity, the dynamism, the globalization, whether it's the spread of disease or the spread of new ideas, really is having transformational capacity.
Trevor, the Gates Foundation operates around the world to prevent disease, alleviate suffering. What about your partnerships with for-profit and the CDC, and how do you feel that they've worked, and what can we learn from your partnerships?
So I have a few graphics over here, Mike, which show some of the partnerships, and I'm going to kick it off, if we can flip to, this is from the polio program, and we'll just watch this little clip over here.
Just 25 years ago, polio paralyzed millions of people in hundreds of countries. Now, thanks to a UN-led global partnership, polio remains endemic in just 3: Pakistan, Afghanistan, and Nigeria.
Nigeria has been on a bit of a roller coaster with polio eradication. Lots of ups and downs in the program, lots of massive outbreaks and then fewer outbreaks.
One of the biggest challenges? Bad maps. Maps that don't show every settlement, every household, every child. Maps that don't show vaccinators where they need to go. In 2012, the WHO worked with companies in the US and Nigeria to build new maps from satellite data backed up by local verification. Meaning no more bad maps. Meaning clear routes that can be tracked by GPS to show where vaccinators are going and where they haven't been. Now, more kids are getting the polio vaccine, and the vaccinator teams in Nigeria can detect problems before they happen.
We're getting this extra 5 to 10% of settlements that we're identifying now at the local area that weren't actually on the original maps. And in the fight to end polio, all of those communities are important.
The fight isn't over. Learn how you can get involved at polioeradication.org. With your help, a polio-free world is possible.
So the message from that was that as primal as the polio campaign is getting out and vaccinating kids, ultimately to be successful, and we really look like we're on the path over there in northern Nigeria, as difficult as it may be, we needed to bring in most advanced technologies. And this involved a private sector company which supplied us with those images. And of course, that type of geomapping is going to be critical in actually delivering other kinds of healthcare into that region and into other regions. And it brings me to this point, which is that in terms of technologies, I think I had the naive idea, and it probably is fairly pervasive, that in the global health area in developing countries, you need very simple things, very simple technologies. But actually the converse is true. Because of the broken delivery systems, actually the hurdles, the technological hurdles of effective interventions are that much higher than in the US and Europe. So for the assembled group over here, we have a fantastic set of capabilities in the private companies, in the academic institutions, at the CDC. And we really need your best technologies, your best ideas to effectively deploy them in these circumstances. We've already had a number of very effective and interesting partnerships. I'd mentioned Kaiser Permanente, where we have a partnership around a social intervention of health clubs. They have walking clubs in the US now, which are intended to combat obesity and other, issues that walking can address. But these are analogous to the adherence clubs that we have in Southern Africa for the distribution of antiretrovirals. We've been working with Becton Dickinson on looking at very simple solutions in terms of diagnostics in the field. So I'd encourage you, in terms of what you're thinking about technologically, bring forward your very best ideas. And it goes beyond just technologies. There's innovation needed on other fronts. And if we flip to just an example over here in terms of what has come to be known as impact investing. Last year, we were supporting the establishment of a global health investment fund. And this is a fund that was supported ultimately by some governments, Sweden, Germany, Canada, private companies. Pfizer was one of the participants in that. And some philanthropies, SIF and ourselves. This is a fund where you would get a return for investing in the fund, and a number of high net worth individuals invested as well. But these would be products for global health, typically products with dual usage in middle income countries as well as in developing countries. It's not just big funds like this, but sometimes small amounts of money can make a big difference as a challenge to people. So I've seen just a tremendous response to our Grand Challenges exploration idea. So this is the idea that for $100,000, you can obtain that if you have a good idea and you send in a 2-page summary of that idea to us. And we've just seen this tremendous response around the globe to the Grand Challenges idea, with a huge number of applications. It is an exercise to actually triage all of them. But it has excited people to the extent that governments have now picked this up. So we have partnerships now with Brazil, in South Africa, India, and Canada, whereby they match, in some instances, this 100K. And it really has led to a hope that you could be anywhere in the developing world, have a good idea, and have some mechanism ultimately to implement it. I just wanted to end with this slide over here, which I think is a real tribute to the partnerships that have led to this amazing decline in the under 5 mortality globally since 1990. And without a variety of the partnerships I've talked about, that wouldn't have occurred. I'll point to one element of this, which is not quite as fantastic. And if you look at the neonatal mortality, this is for kids under 28 days of age, has actually lagged the under 5 mortality. So what this shows is that partnerships have brought us a long way over here, but we are really looking forward to the next generation of partnering with all of you, new interactions that we can establish, address those residual problems, the remaining kids under 5 that die, and this more intractable problem of how do you reach kids in their first 28 days of life. Thank you.
Thank you, Trevor. One of the areas that we've been very focused on over the last couple years are new financial models to finance bioscience, public health, global health, and financing companies and businesses around the world, and how we can create a new paradigm. And Trevor has commented here where a number of people in impact investing are willing to take a substantially lower rate of return in an area that they're very interested in something happening. And these new partnerships and structures, I think you'll read a lot about today. Well, the world has changed dramatically, technology being one. Carmen, but you lead the medical school and the efforts at USC, and for some of you that might not be aware, the University of Southern California, for a very extended period of time here, has the most non-U.S. citizens as students of any university in the United States, more than 9,000 students. And it's not unusual to be able to walk on the campus and see a group of 50 students from China all talking in Mandarin and in the center of the campus today. Carmen, what is the role of medical education in both global and public health? Are the students interested in this field? With the explosion of knowledge, how do you prepare them for the future, whether they're going to be physicians and scientists? And how might universities' systems work better with government organizations such as CDC?
Well, thanks, Mike, for inviting me, and thank you for your advocacy on behalf of the CDC. My connection with the CDC goes back to my first year at Harvard Medical School, where Alexander Langmuir, the gentleman whose auditorium we were sitting in, here he is, he was here for 23 years, and he taught me, after he retired from the CDC, he taught infectious disease and epidemiology at Harvard. And he illustrates the importance of keeping public health on the national agenda. 4 of my most brilliant classmates have spent their career at the CDC, and I actually touched base with 2 of them today. And so this connectedness of the importance of disease prevention, and at this time was really focused on infectious disease, and yesterday we talked about tobacco control and prevention. The evolution, and we can go to the next picture, really, is the creation of institutes of global health at universities. And on the next slide, I have a few slides to show the 12 universities that have that. At USC, here are the ones that are created in the US. And let's go back. And the characteristic of the institutions are really focus on the economic, political, legal, and ethical dimensions of healthcare delivery on a global basis. And we created a bachelor's degree in global health, which is the most competitive undergraduate program to get into at USC. We have a master's program in global medicine. And President Roden commented earlier, young people now going into healthcare have a sophistication and passion for global health that we didn't see in previous generations. And I think that leveraging that enthusiasm with the CDC, with industry, to create opportunities to actively participate in these initiatives would be a fantastic thing.
Thank you, Carmen. Frida, first, one thing about Frida is she is young and energetic, and you, in our interactions over the years, the explosion of energy and creativity has always been characteristic. And Freda, how does a large pharmaceutical company like Pfizer attempt to keep its energy, keep its creativity? How does it work with an organization such as the CDC? And could you touch base on some of your for-profit, nonprofit partnerships?
Sure, excited to do so. First, let me say thank you again. I know it's been said, but I'd like to echo a thank you to you personally for your leadership, to the Milken Institute, to the CDC Foundation, and to you, Tom, for hosting such an amazing day. I want to do a little bit of an intro, which is I've always been a very nervous speaker, and in my young years, my father's eldest brother, my Uncle Big Daddy, suggested.
I don't know everyone heard the name. What
yes,
was your uncle's?
My Uncle Big Daddy. And Uncle Big Daddy said, baby, don't worry about it. When you're talking to a group of people, do your best to be profound. And if you can't be profound, be provocative. And if you can't be neither one, be brief. So, just to let you know, with this panel, I'm not going to attempt profound. And with my passion for the subject, I'm not going to attempt brief. I do want to try to be a little bit provocative, though, and give a couple of examples of what I think are amazing partnerships and collaborations that we, a large pharma company, have currently with the CDC. But I'd also like to share just a little bit about where I think we might be able to go. That would be the provocative part. So we have had the honor of having kind of a tremendous breadth of relationships with the CDC that really represent the breadth of the CDC. So everything from fellowship support and training programs to supporting a smoking cessation evaluation program, which I'll describe in just a second, to collaborative work in vaccine development and deployment. So it really spans the distance of what we do as a pharmaceutical company and also what the CDC does. The smoking cessation program I thought was particularly interesting because it really speaks to that social and political piece that often stands between you and making change. And so in a number of southern states, there was some challenge with small business owners, restaurateurs, people who own bars, to move to a no smoking rule in the belief that it would damage their business. And so we partnered with the CDC in a research project that actually went out and evaluated the potential economic impact on these small businesses. And it was a tremendous report out that supported the notion that their businesses could remain stable, but also an amazing education process with that group of entrepreneurs. So who initially were dug in to fight came to the table in support of the better health of their patrons and their community through providing them with good data. So if those are the kind of typical relationships that one might have, and I know that through the CDC we have many that are similar, many of you here share those. One of the questions that I have is whether or not there's a way to take these relationships to an important next level. So is there an opportunity to do non-traditional partnerships, non-traditional platforms, atypical content with some specificity, or even to develop what I refer to as meta collaborations? And those are collaborations that have three elements. The first would be to really tackle some of the hairy, scary things that face us. Could I use that? I'll do the next slide. So we've heard this morning, I carefully ate my lunch, and I've been walking around like this, and just in case. But we really haven't talked about the power of the CDC to deal with non-communicable diseases. My husband says people don't change when they see the light, they change when they feel the heat. So hopefully I'm going to put up two heat slides. One really looks at the causes of death in the lowest income countries, the other in highest. You'll notice some of the overlap and opportunities for us to do strong collaborations to change the numbers that are attached to these and also the risk factors that are attached to these. So if you look at the most prevalent risk factors in low income or the lowest income and the highest income nations, according to the WHO, there's really an opportunity to have a global impact on things that affect the entire spectrum of people around the world. And the CDC, I believe, is right in the center of that. So if we were going to do something wildly different, what would those partnerships look like? They would tackle these hairy diseases, vexing problems, in the form of prevention as well as treatment. They would also be all hands on deck. So to include not just the elite and key thought leaders, but to go all the way to the grassroots around the world. And then last but not least, would have a demonstrable deliverable so that its long-term goal, such as the eradication programs that the CDC has been involved in with infectious diseases, could we get that same eradication mentality around non-infectious diseases? So I think there's really a keen opportunity for us to shape-shift the kind of partnerships that we have with the CDC and with each other.
I think the slide that Frida put up was so enlightening when you see what are the risk factors in high-income societies today and how dramatically they have changed. And so the efforts that we've heard about a lot, tobacco use, obesity, physical inactivity, that are characteristic in high-income areas, are really have been the enormous drivers of cost to society. And so we have a very diverse group here today of people from dozens of industries, but obviously the largest part of the U.S. economy and ultimately the largest part of the world's economy surrounds these issues of healthcare cost and how do we solve these issues. And what's so interesting in the United States is the issues are really around lifestyle. You can see at the top here of the 4 or 5 drivers, with 70% of all healthcare costs really related to lifestyle. There was a comment made earlier today by Congressman Kingston about our education. And he asked a question during our breakout session, how many of you had learned about what occurred in the influenza pandemic in 1918? And I thought we might, in leading to Tom here, just touch base on some of the facts surrounding what occurred here. So the Spanish influenza moved across the United States the same way as the pioneers had followed their trails, which had become railroads. It went to all parts of America. 675,000 Americans lost their life in this period of time. 40 million people worldwide. And only the Black Death in this period of time, a much higher percentage of the world's population, killed more people, 60 million, in a similar period of time. So it's interesting, the World Bank put out these estimates that a global influenza pandemic would cost the world economy $800 billion and kill tens of millions of people. Deaths in the United States would be in excess of 200,000, and the initial cost just to the U.S. economy would be $166 billion. If you want to go look at this 1918 period, combat-related troop mortalities during World War I. So the number of troops that lost their life from the United States was 1/10 of the civilian mortalities during the flu pandemic, and the rates were the highest in the segment of the population of age 18 to 40. So we can imagine all those that lost their lives, what they might have contributed to our society over time. And I think what Congressman Kingston challenged us is that everybody studied World War I when you went to school. But we didn't have one person raise their hand in the room who remembers studying the 1918 flu pandemic. And Tom, with that, you know, we often talk this morning, and somewhat it follows that line. You told us today, you mentioned Chinese New Year. And explain why an event like Chinese New Year is of concern to the CDC. Maybe we could start there.
Any event anywhere in the world has the potential to affect any of us anywhere else in the world. And there are few things that have the potential, there's actually nothing that has the potential to cause devastation that flu has. In Chinese New Year, we see the largest human migration in the world. 3.6 billion trips, mostly by bus, all around the country, with people mixing. When people mix, you get the possibility of spread of viruses and bacteria and other organisms. So the fact that this is occurring at the same time that we have a surge in the H7N9 influenza that's spreading in China that emerged last April that you heard about is something that we watch very closely, but it's only one of many things we watch closely. We're looking at the Olympic Games coming up in Sochi, and what are the possibilities there, and what are the things that we can do to advise travelers there to be safe. We're thinking about later in the year, the World Cup, similarly. But even when it isn't an event, even when it's just the day-to-day travel that people have around the world, whether you're going into a place where you might be exposed to malaria or drug-resistant organism, or you're getting visitors to the US who are essential to our economy and our productivity, but who also may come with diseases that haven't been controlled in their home country. We really live the fact that we are all connected by the air we breathe, by the water we drink, and by the food we eat. I think that's why it's so important that we move to the next step in partnerships. Government is only as effective as government is supported and pressured to be. My first job in public health was running the tuberculosis control program in New York City. I was about 31 years old. It was the largest and most high-profile outbreak at the time in the US. We had multi-drug resistant tuberculosis spreading in prisons and homeless shelters and hospitals. We had residency programs not matching in New York City because people were too afraid to become physicians there and get infected with untreatable tuberculosis. And I always look around for advice because advice is great. And there are lots of great people who can give advice. And James Wilson was a colleague of a colleague, and he gave the following piece of advice. If you want your program to do the right thing, make sure that there are groups outside of the government pressuring it to do what needs to be done, because otherwise it won't be maintained. And that's so important and one of the crucial functions that civil society can have in moving public health and public policy forward, whether it's the Rockefeller Foundation, universities, industry, philanthropy. They all have crucial roles at keeping government on track. And in fact, the room we're in is a tribute to the advocacy of 3 individuals in Atlanta who got the buildings that you see all around you built with funds from Congress. But there's much more that's needed, not only now, but in the future. For example, with philanthropy, we're thinking about what can we do that is a little bit out of the ordinary, a little bit risk-taking that we may not be able to do with government dollars. We also think, what can we do so that if we have a proof of principle, we can then come in with government dollars and expand that and make that system-wide. What can we do with academia to generate more knowledge and information? What can we do with industry to get new products out to the market faster? Or what can we do with industry to protect markets? For example, a few years back, we identified spread of a deadly organism, listeria, in deli meats. We worked with the industry, cleaned it up. Good for their business, good for health. So there are so many interactions between what we can do. And in preparing for this conference, Mike asked me if you could have 10 areas where people could work with CDC, what would they be? And that's not an easy question, actually, because at CDC we have about 80 divisions, we have about 12 centers, we have about 300 branches, and believe me, every single person working in every branch will tell you, and they'll be able to convince you why their program is the single most important thing that we do. One of the unique characteristics of CDC is that we're both broad and deep. We have expertise in virtually every area of health, and the experts that you see here and the more than 15,000 people who work for CDC around the country and in 50 countries around the world, many of them are spending their entire career focused on CDC, focused in an area or in a country or in a commitment to an issue that makes them not only experts but effective at effecting change. And if we could just show that list of 10, I'll give you a sentence on each. Fundamentally, you can think of the dichotomy of US or global and the dichotomy of infectious or non-communicable. They're all important. There are things to be done in all of the areas. Global health security, an area where our security and safety is dependent on what other countries do, and yet 80% of the world hasn't met the basic requirements of finding, stopping, and reporting disease. Antimicrobial resistance, where we have important partnerships with industry, some in this room, not only to create new antibiotics, but also with the American Hospital Association, Richard is here, to better use antibiotics so we protect them. We're diligent stewards of these resources. Advanced molecular detection, you had a session on this before. It's very exciting. It's going to be a lot of heavy lifting to turn a great idea into great programs. Figuring out how to not only have EIS officers, you've heard about the Kate Winslet model of the Epidemic Intelligence Service. It's a fantastic program that Alex Langmuir started more than 60 years ago, a 2-year service learning training. It's what I call interventional epidemiology. It's not about describing, it's not about analyzing, it's about intervening. We need that kind of program for implementation officers, for people who are going to find and stop and implement programs. The Million Hearts Initiative, and if we can go to the slide on health systems, heart disease and stroke are leading killers and yet largely preventable. So if you look at what we can do, whether it's tobacco control or improved nutrition, you can see that we're a long way from where we need to be. And it's not only about clinical care, it's not only about community health, it's both of them. And doing both of them together can make an enormous difference. Water, sanitation, hygiene. The Gates Foundation is doing some terrific work here. Judy, you mentioned the great work that Rockefeller has done and is doing in this area. But there are a few things that can have the kind of impact that those interventions can, and there are exciting new technologies that may allow us to install systems in smaller and smaller communities or more cost effectively in large communities. Much of what needs to be done in low and middle income countries is not very different from what was done in this country and other higher income countries 50 or 100 or even 200 years ago. Vital registration, clean water, good roads. Drug overdose is a problem that we've seen as a huge epidemic in this country. We have underuse of some medications, for example, for high blood pressure, and we have overuse of others, for example, opiates and some others. And then there's community-wide health improvement, whether you're interested in the community of your workforce, the community in an area of this country or overseas. And blood pressure control was one of the few things that was at the top of both of those lists. So whether it's infectious or non-infectious in this country or abroad, industry, academia, or philanthropy, there are great ways that we can work together, and it's only by working together that we're going to get so much more done.
I just wanted to add a point about industry, because as someone from the pharmaceutical industry who has been in other parts of the health industry, I think it's really important to not forget that this is not just about the biotech or the biopharma industry as potential partners. That non-traditional partnerships are really critical. I think to your point in this space, it becomes a leverage point if you look at communications technology and the way that it can be used. If you begin to look at using partnering with media organizations, for example, to get the word out, if you would, to our constituency and to communities. So if you can learn about bad habits, you ought to be able to learn about good health habits and things that would advance your health. So employers, large employers, as a way to get to people that otherwise would be 2 steps removed from us in a partnership. So I just want to underscore the idea that from an industry perspective, we're not just talking about those of us that stand as traditional health companies, but it really is about all of the opportunities to bring resource, knowledge, information, technology, and network to the table.
Mike, can I jump in? I think that we run, and excuse me, I'm post-Davos kind of grunge. we run the risk of thinking that in the developing world we will transform health systems by bringing them the same kind of healthcare and the same kinds of healthcare systems that we have in the developed world. We have an opportunity now to critically leapfrog over the way that we provided healthcare, or that healthcare was provided for us. We know how expensive healthcare has become in the United States, and so I want to emphasize that we have mobile technologies. When Kenya introduced M-Pesa for finance, it transformed the opportunity for access to finance for millions of poor people in Kenya. We are seeing incredible mobile health innovations. I was in Minoshi Brock project in the slums of Taka, and a barely literate healthcare worker put a cell phone kind of device up to a woman's arm and took her blood pressure. The tertiary care facility text messaged her, give her the pink pill. They didn't say this was gestational hypertension. It took 2.5 minutes. It was incredibly inexpensive. We're not doing that here. So all of these opportunities to really take these greenfields, if you will, and experiment in ways that not only transform their health systems, but really give ideas back to us about how we can cut healthcare costs. There's so much innovation going on. We've been using, and we talked earlier about crowdsourcing. You know, all of the R&D isn't occurring only in the laboratory, whether it's inside Pfizer or inside USC. The opportunity to really get that last stage R&D anywhere in the world now not only gives people extraordinary opportunities, but really gives us a kind of innovative new way of framing and looking at things, because we're not trapped in our same prisms. So one of your peer companies, Eli Lilly, spun off a for-profit, turned into a for-profit group called Incentive, and they post prize money for that last mile R&D solution. And they have 40,000 people registered from all over the world. Many of them are not inside universities or research labs, and yet they're getting these extraordinary innovative solutions. So I think we're at a real turning point where we have the opportunity to understand when and how we use big science, and when and how we use small science and small technology together in a way that could have a catalytic and transformational effect on health going forward into the future. And I think it's a very pivotal moment.
I think to follow up on what Frida and Judith have both pointed out, there isn't anyone here in the audience that hasn't been in some developing country, Botswana, in the middle of nowhere, and wish that your cell or mobile phone worked as well here in the United States as it works there. And so the idea that you're going to, I think the important point Judith has made, that we're going to reproduce an existing system with modern technology changing everything, it's just not going to occur. And the ability to communicate is so significant with 7.3 billion mobile devices and a large percentage of them smartphones, and whether we're taking your blood pressure, ultimately checking your glucose levels via these devices, or eventually taking your EKG or whatever measurements we are that are then fed back into a central. The other thing I think that both Frida and Judith touched on here were non-conventional partners, crowdsourcing. All of you have increasingly heard stories of crowdsourcing in any areas, whether it's oil spills or who's going to be in the hospital next year. And more than 50% of the people that are involved in finding those solutions aren't in that field. So you've essentially checked everyone in the world, and the potential to have anyone working for you to find a solution. We often point out that a former partner of mine, Larry Ellison, has spent $500 million winning 2 America's Cups. What did he win? He won 2 America's Cups, and the satisfaction that he holds those cups today. There was no financial prize. There was a personal prize as a competitor. And so many people around the world, many of them don't even know there's financial prizes when they're trying to solve a problem today. And so this revolution of data has changed. Last night we showed you a brief video of a young man, Jack Andraka, 15 years old, accessing data that was available for him to try to think of a new way to create a test for early detection of pancreatic cancer. And so as data is available, we're going to have this revolution, whether they're in high school like Jack or in college or graduate school today. And I think one of the areas, Trevor, we ought to focus on is let's talk about the lessons of polio. And, engaged in this area, who cares and who's focused on sub-Saharan Africa? Well, obviously Chevron and the major energy and mineral companies, they're there. They're not moving. The financial companies, they're not moving. Are there lessons that we could learn for the foundations and others in the audience that if you had these things more effective, we could be more effective for you?
Well, Mike, in the polio campaign, the one thing that we found is we would love to have a certain set of tools at this point in the game, which we are actually playing a little bit of catch-up in developing. But the thought was always, well, this is going to be easy. It's going to be a cakewalk, and we're almost there. The number of cases is in the hundreds, and it's just a matter of cleaning up. But it's that last mile which is so difficult. And wow, now do we really wish we'd made those investments 10 years ago in some of the tools we could really use. Now we're in the very difficult game that you saw in northern Nigeria, where we're having to bring in all of these other new types of technologies. But in terms of the partners that we could use in sub-Saharan Africa, I think there are a number of very interesting anecdotes around this which indicate what could really happen with industry, for instance, moving in. There's the situation in Ghana where Angloval Shanti, a mining company, a gold mining company, what they did was they were actually very effective in malaria control for mainly their workers around the gold mine, to the extent that the government, seeing this, obtained some funding from the Global Fund actually, to actually pay this mining company to extend the extent of their malaria control to about 44 districts. And there's a huge amount of this industrial activity that I think could really be captured for tremendous effect and using capabilities that we don't have to reproduce.
Carmen, there's one thing. There are 4 of the panelists here that went to medical school. How has medical education changed since you and Tom and Frida and Trevor went to medical school, and what are the students looking for, and how are you reshaping what a medical school experience is?
Well,
and be careful with the time frame that you're referring to.
Right. Well,
I'm just giving you,
I'm reflecting on when I went to medical school. It was before Legionnaire's disease and before HIV/AIDS, which really demonstrated the power of medical detective work in general. I think students, because of instantaneous communication, they're interested in global activities. The question is how I think intellectual capital is key. We need to have smart people that want to work in public health, that want to work at the CDC, and we need to have strategies to get them involved in these campaigns. I think in some sense we have chances for internships and overseas experience, but not many real job opportunities for folks. But to me, it's extraordinary the level of interest and commitment to that.
I think this is something that maybe all of you haven't realized, but if you go to Johns Hopkins, for example, their bioengineering program, they're limiting it to 25% of students. You can't apply to your sophomore year. My guess is 50 to 75% of all students would be in bioengineering. if they could. And I think, Carmen, you've underlined that with the interest in global health and public health. Frida, I'd like it if you could touch base. When we talk about partnerships, maybe we can put up that little snake here and take a look at it if we could find it, and just understand how many parts there are to the puzzle here. This was Ben Franklin's cartoon, 1754, where he was trying to explain that we needed to join or die in a message. This is another cartoon iteration of it, 2014, with the Centers for Disease Control and Biopharma and Philanthropy, led by Judith here and Trevor, our employers, etc. And the teamwork capability. One of the areas that we've been very focused on, as you know, Frida, is the strengthening at Faster Cures of the disease-specific organizations with our train program, etc. Could you maybe talk about those partnerships and how they've worked?
Absolutely. Well, first of all, I think that they are truly empowering partnerships for those of us that didn't traditionally engage in them, and they are not your, granddaddy's collaborations anymore. Patient organizations have brought to the table an amazing match of access to patients, a sophistication around collecting data and providing longitudinal data and information, access to patients for recruitment into clinical trials, which remains a horrific burden for those of us who are trying to advance cures. These organizations and individuals that they represent are bringing different political and societal pressure, Tom, to your earlier point, and have become highly sophisticated in articulating cases and taking them to people who can make decisions and change direction. And also the financial platform that is occurring now with patient-focused organizations is quite striking. A couple years ago, about a year and a half ago now, we, Pfizer, announced a relationship between the Cystic Fibrosis Foundation, in which the Cystic Fibrosis Foundation brought $58 million to the table to provide support to Pfizer to advance research. Well, when the press release went out, people called, I'm sorry you made a mistake. You meant to say that $58 million went from Pfizer to Cystic Fibrosis Foundation, right? No. Our financial platform and the kinds of resources that are brought to the table in these atypical collaborations are quite striking. And for all of these opportunities that empowered patients bring, they also bring a connection to resources that you otherwise wouldn't think about entertaining. And I want to digress just a second from the patient-focused organization, because we were introduced into an opportunity as the Pfizer organization to do something that we heard from patients was necessary. And that was, they did not necessarily have the power to do the outreach, the awareness, and provide the education. And in some cases, they didn't just need money, but sometimes they needed access. And so we as a company were able to develop a relationship with CBS to provide education and outreach on a variety of topics through their CBS television platform, particularly The Doctors, which is an afternoon television show about health issues, and four physicians are the kind of hosts of that, and The Dr. Phil Show. And if I have a quick second, I want to play a clip. This doesn't have anything to do with Pfizer, but it is baseline education that happens through the Doctor's television show in partner with CBS that provides education and information to that audience, which happens to be a little over 2 million people who are sitting there on that day, and a whole length of pull-through in the digital media that CBS provides around the show. Could you? There won't be much of me, I promise.
Now, some people choose not to have themselves vaccinated or their children vaccinated. One of the reasons that they talk about is risk.
Like any medication, vaccines can have side effects. For the most part, though, they're minor side effects. We're talking about a sore arm where you get the shot, maybe a low-grade fever as your immune system gets into place for a few days. Vaccines are continually monitored for safety, more so than almost any other thing that we provide patients. But a decision not to get immunized could put you, as well as others who come into contact with you, at risk of a potentially deadly disease or disabling one like polio.
I think the point that I wanted to underscore with that, and the content of it, not probably as important as the notion of it, is that who would have thought that the power at the point of reaching patients might come from such an atypical relationship as a pharmaceutical company and a media company such as CBS. So we think that there are important opportunities, and many times it's the patient's voice that comes to you, the insights that they provide, in addition to all those other things that I just mentioned that provide the kinds of partnerships that get these things done.
I think one of the other things I'd like to just put forth to you is we often hear that no good deed will go unpunished. Okay, so you can think about whether you're working at the CDC or the mayor of Atlanta the last few days. And it was a number of years ago, it's probably 3 years ago, Frida, maybe a little more now, that Frida had just come back from having Thanksgiving with her family. And she told me, here is a young woman who went to medical school. She's the chief medical officer of the world's largest pharmaceutical company, was on the president's, one of 20 people on the president's panel. And she spent her Thanksgiving defending her career choice to her family over Thanksgiving weekend. And they told her she had so much promise. One of the brightest kids from her neighborhood. They were all proud of her. She went to medical school. She had a great career. And why did she sell out and join a pharmaceutical company? And I think this is our challenge. We've talked a lot about the communications of what is the role of the CDC, and I just want to, remind every single one of you, when we end at 4 o'clock today, you have a chance to go through that museum and see the CDC through your own eyes. But the challenge on a career where you went and followed a path that you felt was going to change the world for better, and then defending your career choice to your own relatives, your own family, at the dinner table for Thanksgiving. I think we somewhat forget where we've come from. When 1 in 5 Americans lost their life by the age of 5, 20% of our population at the start of the 20th century. Many of the deadly diseases we've controlled in the 20th century found their success or the success in controlling them at this organization, the Center for Disease Control, and whether it was chickenpox or invasive flu or measles or polio or yellow fever and these other areas. It's been such an important part of our life, but and the reason we're here is part of our Celebration of Science tour, and thank you for joining us, is really to try to really focus on these issues that we just don't focus on, and life gets in the way sometimes, and we just don't step back and have a chance to think about it. So Tom, we want to thank you for your hospitality. Judith, we want to thank you for your service, not only at the University of Pennsylvania, which both Carmen and I have degrees from, but at Rockefeller in your leadership. It's made a difference. Carmen will be following the School of Global Health and Public Health closely. Frida will be watching your television show more often. And Trevor, we're all in awe of the potential partnerships with Gates and your efforts. So I want to thank you for joining us today.